Assalamu alaikum. Our lecture today is about rickets. In this lecture, we're going to focus mainly on one type of the ricket, which is nutritional rickets. At the end of this lecture, you should know the definition of rickets, the causes and types of rickets. Also, we're going to discuss the vitamin D physiology, function, and what's factor that regulate vitamin D. Also, we're going to focus on the clinical manifestation of rickets and how we can reach a diagnosis. And lastly, we're going to speak about nutritional rickets, what are the causes, what is the treatment, and what is the prevention. Rickets and osteomalacia. Both rickets and osteomalacia result from inadequate vitamin D effect. So in both conditions, the bone will be softened, friable, and easily fractured. The difference in between the both conditions is that rickets occur before closure of the growth plate, so it will affect the growth of the child, while osteomalacia occur after closure of the growth plate, so it does not affect the growth of the child. However, in both conditions, the patient will is liable for having fractures. We can divide types of ricket according to its etiology. The first type is vitamin D disorders, which is a result in nutritional rickets, congenital ricket, secondary vitamin D dependent ricket, which is consists of two types, type 1 and 2, and we have rickets that occur in patients with chronic renal failure. The second type is ricket that result from calcium deficiency, which could be occur either due to inadequate intake or more commonly from malabsorption of calcium. Third type is the ricket result from phosphorus deficiency. We have an inherited types of ricket which is called X-linked hypophosphatemic rickets. Lastly, we have syndromes and disease that is associated with rickets, for example, the Fanconi syndrome, distal renal tubular acidosis, and finally, Dent disease. Vitamin D physiology. The most important source of vitamin D in our body comes from cutaneous synthesis of vitamin D in the epithelial cells in the skin. This is occurred by conversion of 7-dehydrocholesterol to 3-cholecalciferol by using ultraviolet B radiation from the sun. However, this synthesis depends mainly on the amount of sun exposure and less duration covering the skin with a cloth, skin pigmentation, and seasonality are less efficient in vitamin D synthesis. In addition to cutaneous synthesis, we take vitamin D from natural dietary sources, for example, fish liver oil, egg yolk, plants, or yeast. Vitamin D is a fat-soluble vitamin. It is stable to heat, acid, alkali, and oxidation, and bile is necessary for its absorption. Vitamin D is transported in our body binding to a protein to the liver. At the liver, under the action of the enzyme, which is called 25-hydroxylase, it will be converted to 25-hydroxyvitamin D. This form of vitamin D is the most abundant circulating form of vitamin D. It is the standard method for determining the vitamin D status of the patient. The final step in the activation of the vitamin D occurs in the kidney under the effect of the enzyme 1-alpha hydroxylase. It will add a second hydroxyl group which is result in 1,25-dihydroxycholecalciferol. This enzyme is upregulated by parathormone and hypophosphatemia. The active form of vitamin D in our body is 125 dihydroxycholecalciferol. The action of this form of vitamin D is on target organ of the intestine, bone, and the kidney. On the intestine, this form increases the absorption of calcium and phosphorus. In the bone, it will mediate bone resorption. And on the parathyroid hormone, it will suppress parathyroid hormone secretion. And finally, in the kidney, it will inhibit its own synthesis. Vitamin D can be obtained from various sources, including diet and exposure to ultraviolet sunlight. However, vitamin D from these sources are not biologically active and cannot achieve its action in our body unless it is activated. Metabolic activation of vitamin D consists of adding two hydroxyl group. The first one is 25, which is occur in the liver. The second one is 1, which is occur in the kidney. The final result is the most biologically active 125 dihydroxy vitamin D. So any break in this process, such as inadequate intake, inadequate sunlight exposure, or the patient having liver kidney disease, it can lead to deficiency of active form of vitamin D. Clinical manifestation of rickets, including first, in the general, we can see patient will have failure to thrive, restlessness, you will have protruding abdomen, muscle weakness, especially the proximal muscle. Also, the patient will have delayed walking or waddling gait, and in severe cases, he may develop fractures. On the head, the first sign will be craniotabes. This is a feeling of ping pong feeling when pressing on the bone. Frontal boozing, delayed frontal closure, delayed dentation, and craniosynostosis. On the chest, you can feel a rickety rosary, Harrison groove, and on severe cases, the patient will develop respiratory tract infection and atelectasis. Different types of spinal deformity, the patient will develop scoliosis, kyphosis, lordosis. On the extremities, the patient will have enlargement of the wrist and the ankle, different deformities of the lower extremity, for example, valgus, varus, wind-swept deformity, anterior bowing of the tibia, coxavara, and the patient may have pain. On delayed cases, delayed diagnosis, the patient may develop symptom of hypocalcemia, tetany, seizure, and stridor. These are examples of the deformities on the lower extremity that's seen in patients with rickets. You can see that the patient may develop knock-knee, bow leg, or a combination of those when he develops a wind-swept deformity. Diagnosis of rickets. In order to diagnose rickets, we have to take an X-ray of the wrist, usually the left wrist. In an AP view, you can see thickening of the growth plate, fraying, cupping of the distal end of the metaphysis. Also, you may see a coarse trabeculation of the diaphysis and generalized rarefaction. Laboratory test then came first. It will support your diagnosis. This table shows the lab result in a patient with rickets. You can see that in different types of rickets, the patient will have normal serum calcium. Unless the patient have severe form and neglected form of ricket, then he may develop sign of hypocalcemia. This is lateral and AP radiograph of the wrist, which show cupping and fraying of the metaphyseal region. A helpful mnemonic for remembering an X-ray finding of ricket is the R, which is standing for reaction of the periosteum, the I for indistinct cortex, the C for coarse trabeculation, while K for knee, wrist, ankle, which affected predominantly. E stands for epiphyseal plate widening and irregularity, while T for tremendous metaphyses, when the metaphyses show cupping, fraying, and splaying. And finally, S stands for metaphyseal spurs. Now we're going to discuss an important type of ricket, what's called nutritional vitamin D deficiency ricket. Nutritional vitamin D deficiency ricket, it is the most common type of ricket globally, mostly occur in infancy. This results from combination of inadequate intake or inadequate cutaneous synthesis. The transplacental transport of vitamin D usually provide enough vitamin D for the first 2 months of life, unless there is severe maternal vitamin D deficiency. Infants who receive formula usually receive an adequate vitamin D even without cutaneous synthesis. However, because of low vitamin D content of the breast milk, especially if the mother also having deficiency of vitamin D, so breastfed infant rely mainly on cutaneous synthesis or vitamin D supplementation. Treatment of nutritional rickets. Nutritional rickets is treated by vitamin D. It's given in therapeutic dose. We have different regimen of treatment. We either give the patient a therapeutic dose, daily oral therapeutic dose of vitamin D in a range of 2,000 to 5,000 international units per day over about 1 month and 1.5 months. Or the other regime is we give a very high dose of vitamin D, which consists of 300,000 to 600,000 international units of vitamin D, um, either orally or intramuscularly. We divide this high dose into 2 to 4 doses over 1 day. This is called a dose therapy. Whatever the regimen that we used, all patients should be receive after that a maintenance dose of vitamin D, which consists of 400 international units per day if the child is less than 1 year of age, or if he is older than 1 year, then we give 600 international units per day of vitamin D. In addition to vitamin D, it's very important to ensure that the patient have a good sun exposure. Also, the dietary calcium and phosphorus should be enough. For those children who have a symptomatic hypocalcemic symptom, then initially we have to admit the patient to the hospital and treat him with IV calcium. After he shows a sign of improvement, then we shift the patient to oral calcium supplement as an outpatient. We usually taper the dose over 2 to 6 weeks. We also may give the patient IV or oral 125 dihydroxycholecalciferol. Prognosis of nutritional rickets. With appropriate therapy, the laboratory test results usually normalize rapidly. However, X-ray findings usually take long time to normalize. Many of the bone malformation will improve dramatically. However, children with severe disease, of them will have permanent deformity and some of them will end up with short stature. Prevention. Most cases of nutritional rickets can be simply prevented by administration of daily multivitamin of that's containing vitamin D. For children below 1 year, we can give 400 international units of vitamin D. And those older than 1 year, we can give 600 international units of vitamin D daily.